So when you're carrying out body taping, it's important to explain to the patient what the purpose is. So in this instance, we're going to say that the index finger is injured. So we explain to the patient that the middle finger is going to, because it only has a normal range of motion, it's going to prevent the index finger from going beyond what it should normally do. But it's also going to encourage the index finger to move, because every time the middle finger moves, the index finger is going to move. So in order to do the buddy taping, you need some gauze. I find these smaller ones are easier because there's less cutting to do to get them to actually fit the size that you want. You want it to be the length so that it goes in between the fingers, and you don't want loads of it sticking out the end because that just ends up looking really messy. In terms of the tapes that are available, a lot of people reach for the micropore tape, but the micropore tape has no give in it. It's often difficult to find the end of it, and it tears quite easily once you actually start them moving. It very rarely survives what you want it to survive in order for buddy taping to be effective. So we'll leave that one aside and not use that one. So a lot of people will use this type of tape for buddy taping, which is fine. And it comes in different widths to this. So if you're doing a child, for instance, it's more there's more variation in order to make sure that you're fitting the size of the child. The Elastoplast does have some give in it when you're doing it, and my preference is to use Elastoplast. However, whichever one of these two you use, when you apply it, it's important to ensure that you don't apply it on the stretch. When you start, I think therefore it's a good idea not to be unravelling it as you're applying it, but to take it and cut off what you think is a reasonable length for you to use. It doesn't matter if you then have to shorten it afterwards, but you've then got a piece of tape that you can apply without constantly stretching it out. So if you take the patient's hands, what you want to do is you want the joints to be free. So it's not a case of doing it parallel up the finger, it's a case of doing it over the proximal phalanx and then over the middle phalanx. So you place it on without it being under tension, and if necessary, you trim it off if there's an excess. And then the same again at the level of the middle phalanx. You see how I'm going to go diagonally there in order to leave the distal interphalangeal joint free to move. And then if you just ask the patient to turn the hand over and make a fist, you can ensure that there is the allowance for full movement. Obviously you need to explain to them that if they notice that any change in colour of their finger or a sense of that it is too tight, then it needs to be removed and redone. So it's fairly straightforward on the index, middle and ring fingers. The difficulty comes when it's the little finger that is injured. So I'll just show how much that can end up being diagonal, because people often they underestimate how obliquely you need to go. So we're going to need to cut off a bit of that. And on this occasion, we'll use the white one just to show the difference. But in order to go from proximal phalanx to proximal phalanx, you can see it is quite oblique that you're going. And in order to come back again in the same direction and come around, it does leave a slack bit here which you then need to deal with. Middle phalanx, cross middle phalanx, no tension. And then just pinch in that bit. If you've got a bit that you can stick down around to make it to neaten it in, that's even better. Okay, so if you turn your hand over, oops, that's make a fist for me and straighten out. So I think if this is a live patient, I'd probably redo this one in order to make it a bit more secure, because it looks as though it's moving around a bit. But you get the idea. The distal phalanx, you don't need to wrap it right up to the end of the finger. What you're doing is you're going middle phalanx to middle phalanx and proximal phalanx to proximal phalanx in order to allow the whole digit to be able to move.